Good evening, everyone, and let me welcome you to the SCAI Secondary Prevention webinar. Let me start the proceedings by introducing Dr. Timir Paul, who is our team lead. Dr. Paul is a professor of medicine and interventional cardiology at University of Tennessee Health Sciences Center, College of Medicine at Nashville. He's also the program director of the Cardiovascular Medicine Fellowship. Dr. Paul?
Thank you, Dr. Mukherjee. Welcome to our SCAI Secondary Prevention webinar, focusing on optimal lipid management. The Secondary Prevention for Atherosclerotic Cardiovascular Disease Toolkit and this webinar is supported by Amgen. I would like to introduce my co-moderator, Dr. Debabrata Mukherjee. No introduction actually needed. He's the chair for the Department of Medicine and Chief of Cardiovascular Medicine at Texas Tech University at El Paso. But most importantly, he is involved and was involved in many guideline writing committee, including authors, and recently was a co-chair for our chest pain guidelines. Our speaker, Dr. Faisal Latif, and also on the panel, Dr. Faisal Latif is a clinical associate professor at the University of Oklahoma and director of cardiac catheterization laboratory at St. Anthony Hospital in Oklahoma. Dr. Jacob Dahl is our another discussant today, who is an interventional cardiologist and a researcher at the Washington VA and also in the University of Washington. I also would like to introduce Dr. Shia Hogan as a discussant, and on the panel, Dr. Hogan is an interventional cardiologist and an assistant professor of medicine at the University of Colorado School of Medicine. Now we'll start our first half of our discussion and talk started by Dr. Latif.
Thank you very much, Dr. Paul. Welcome everyone to this educational activity based on something we interventional cardiologists may not do as much, and that is optimal prevention, secondary prevention for patients who already have established cardiovascular disease and how to manage their lipids. The objectives of our talk today include recognizing system-level gaps in the care of our patients who have had percutaneous coronary interventions, documenting and communicating across the care team to ensure that our patients receive optimal guideline-directed lipid-lowering therapy for secondary prevention, and empowering patients with knowledge necessary to make decisions about setting and achieving their target lipid levels. Next slide. So there are many gaps in our overall assessment of cardiovascular risk in patients with established cardiovascular disease. For example, only half of the patients who are undergoing PCI for an acute coronary syndrome have a lipid profile documented during their hospitalization. Only 35% of patients who had a PCI have a repeat lipid panel within 6 months of intervention. And a lot of evidence has shown that unless we are controlling their lipids quite well, they are at significantly increased risk of repeat events. Many PCI patients do not receive guideline-directed medical therapy. Many of them are not even on appropriate antiplatelets and not on statins. Tailoring therapy based on individual risk factors can improve outcomes of these patients and also reduce hospital readmission and rehospitalization costs. Particularly speaking for minorities and underserved populations, have had a higher burden of cardiovascular disease and are even less likely than others to receive guideline-directed secondary prevention medical therapy. Next slide. There are many options for treatment of lipids. First and foremost are statins, with a track record of decades now in reduction of cardiovascular events, particularly MI and stroke. Ezetimibe is an important piece of that pharmacological option. Armamentarium, PCSK9 inhibitors have been available for a few years now. Inclisiran, which is siRNA directed to PCSK9 inhibitors, PCSK9 receptors, omega-3 fatty acids, and icosapent ethyl, which have strong data for mortality now, bempedoic acid, which again has shown improved cardiovascular outcomes in addition to lipid lowering, fenofibrates for triglycerides, and finally LDL apheresis for select patients. Next slide. So lipid goals in atherosclerotic cardiovascular disease have recently changed, and we as interventional cardiologists should be at the forefront of managing lipids in these patients, particularly in patients who are at very high risk of atherosclerotic cardiovascular disease. The target LDL based on the 2022 ACC expert consensus decision pathway is less than 55. It's not less than 70 anymore. It's less than 55. Both LDL reduction by greater than 50% from baseline and LDL goal of less than 55 has been part of European guidelines since 2019. Patients with diabetes and established cardiovascular disease target of an LDL cholesterol reduction of 50% from baseline and LDL less than 55 is also based on the new guideline from American Diabetic Association published in 2023. So all in all, we should be targeting a goal of less than 55 for patients who are at very high risk of atherosclerotic cardiovascular disease. Next slide. So which patients are the major risk patients? So patients who have had recent acute coronary syndrome within the past 12 months, history of MI other than recent ACS event ever, history of ischemic stroke, symptomatic peripheral arterial disease, such as those who have claudication with an ankle brachial index of less than 0.85, or previous revascularization of lower extremities or any or carotid arteries, for example, or history of amputation. So a lot of, you'll see that a lot of our patients that we see as interventional cardiologists fit this bill of having or being at risk of major cardiovascular events. High-risk conditions also play a role, such as age greater than 65, heterozygous familial hypercholesterolemia, history of prior CABG or PCI outside of a major cardiac event, diabetes, hypertension, chronic kidney disease with a GFR less than 60, current smoking, persistently elevated LDL cholesterol greater than 100 despite maximally tolerated statin therapy and ezetimibe, and history of congestive heart failure. Next. So the first-line treatment to achieve the target LDL goal is to use a high-intensity statin therapy, or at least maximally tolerated statin therapy. That's a class 1 indication based on guidelines. If LDL is greater than 70 while on a statin, as a first line, add ezetimibe to the maximally tolerated statin. That's a class 2A indication. And then when to add a PCSK9 inhibitor is the next major question. In very high-risk patients, if LDL remains greater than 70 or non-HDL cholesterol is greater than 100 on maximally tolerated statin and ezetimibe, then PCSK9 inhibitor should be added. If LDL is greater than 55 while on statin in very high-risk patients, consider adding ezetimibe or PCSK9 inhibitor to the maximally tolerated statin therapy. And then patients with statin intolerance are also good candidates to add PCSK9 inhibitors. Next. So here is a proposed algorithm which is based on the 2022 ACC expert consensus decision pathway. So I'll walk you through it. Patients who have established cardiovascular disease, that is, these are patients who have already had an event, and now we are talking about secondary prevention. We should be checking their LDL level. If they are not on a high-intensity statin, then they should be on a high-intensity statin, which, by the way, includes only 2 statins, atorvastatin at a dose of 40 to 80 milligram or rosuvastatin at a dose of 20 to 40 milligram. We should be rechecking their LDL levels within 6 weeks. As I alluded to earlier, only 35% patients get a repeat lipid profile in 6 months, but our current guidance says that we should be rechecking LDL levels within 6 weeks. In patients who are at very high risk, to the right side of the cartoon here, if LDL is now less than 55, great, continue that. If the LDL still is greater than 55 at 6 weeks, then consider adding PCSK9 antibody, or even could consider bempedoic acid or inclisiran as a second-line therapy. In patients who are not at very high risk, if their LDL is less than 70, then you can continue statin and check LDL annually. In patients whose LDL is still above 70, then add ezetimibe. If their LDL gets to below 70, great, you can continue statin and ezetimibe and check their LDL annually. If the LDL is still greater than 70, then consider PCSK9 inhibitor. Now, it's important to reassess LDL in 6 weeks or annually, depending on where they are. Once the patients reach their target, then it is okay to check it once a year. But until they have not made it to their target LDL based on their risk, then their LDL needs to be checked much more frequently. Next slide, please. Statin therapy, it is important to understand that high-intensity statin therapy, that is the high doses of atorvastatin and rosuvastatin that I just mentioned, it lowers the LDL by about 50% or greater. Moderate intensity statin decreases LDL by 30 to 49%, and low-intensity statins by less than 30%. And I'll show you how much each statin does here in a moment. Randomized controlled trials have consistently demonstrated that statin reduces the risk of major events by 21 to 23% for each millimole reduction in LDL during each year after the first that it is taken. So you can see a very major decrement in the incidence of cardiovascular events in patients who are on maximally tolerated medical therapy and maximally tolerated statin therapy in reduction of hard cardiovascular outcomes. The benefit of therapy depends on the individual's absolute risk of ischemic events and the absolute reduction in LDL cholesterol. Statin therapy reduces vascular disease risk also during each year of continued therapy with persistent long-term benefits. Next slide. So here is a graph that shows how much we expect the LDL to go down with each statin. So as you can see in green, that rosuvastatin 20 to 40 milligram or atorvastatin 40 to 80 milligram is what reduces LDL by about 48 to 55%. And the ones in yellow are the moderate intensity statins, which reduce the LDL by about 30 to 45%. And then low intensity statins reduce it less than 30%. And with this, I will hand over to Dr. Paul.
Next slide, please. Now, I'm going to briefly discuss the 2018 guidelines and also individual evidence for non-statin therapy for high-risk patients. So if patients with established atherosclerotic cardiovascular disease, but not at high risk, if patients are less than 75 years old, start high-intensity statin to lower LDL cholesterol by 50% is a class 1 recommendation. However, if they cannot tolerate the high-intensity statin, using the moderate intensity statin is also a class 1 indication in this age group. But if patients are more than 75 years old, if they are already taking in high intensity or moderate intensity statin, continuation of high intensity statin or moderate intensity statin is reasonable. But patients with SCVD and at very high risk, regardless of their age, they should be on high-intensity statin or maximally tolerated statin, and these are class 1 indication. Next. So how do we follow up and monitor statin therapy? So when we start the statin therapy, we always get the baseline, and then for every dose adjustment, we should check the lipid panel and also a liver function test 4 to 12 weeks after to assess the safety. And also, every 3 to 12 months thereafter, if we need to assess their adherence and also safety. In patients with chronic liver disease, if they are stable, including the non-alcoholic fatty liver disease, using the statin is reasonable after assessing the baseline measurements and also continued follow-up as indicated before. So in patients with severe statin-related muscle symptoms, muscle pains, even after adjustment of the statin therapy, it is reasonable to use non-statin therapy to reduce their LDL up to the goal and to get the net clinical benefit. So there are multiple non-statin therapy that we'll be discussing in next few slides if they are statin intolerant. However, if they have a side effects from the statin use, coenzyme Q is not recommended, it's a class 3. At the same token, routine measurement of the creatine kinase or liver function test is not useful. Next. Women who are at childbearing age or who have a history of premature menopause or pregnancy-associated hypertension, gestational diabetes, or if they have a preterm deliveries or preeclampsia, those are the patients are high risk for subsequent atherosclerotic cardiovascular disease and events. So when you discuss about the lifestyle intervention with those patients and family, we should always talk about the benefit of the statin and likely start the statin as indicated by guidelines. Statin is contraindicated during pregnancy. So if someone got pregnant and if we know that they're on statin, we should stop the statin as soon as we know. Also, if someone wants to get pregnant, and we should stop the statin 1 to 2 months before the pregnancy start. Next slide. So ezetimibe has been approved for many years for lowering cholesterol, especially the LDL cholesterol. In 2015, the IMPROVED-IT trial that included 18,000 patients with SCS. They compared ezetimibe plus simvastatin versus ezetimibe, and they looked for 7-year cardiovascular events, and it showed that significant reduction of cardiovascular events. Ezetimibe decreased LDL by additional 18%, either as monotherapy or if we start on top of statin. So the patients who cannot take the statin, ezetimibe is a reasonable good option. Next. Bempedoic acid has been approved since early 2020. It's easy to use the drug. It's oral medication, 180 milligram once a day. And it should be used as an add-on therapy if their LDL is not on goal, if they are intolerant, or if they're already on maximally tolerated doses, either alone with statin, with or without ezetimibe too. And it decreased the LDL almost identical that ezetimibe decreased if we use on top of statin. Interestingly, if we are patients not on statin, and if they are on ezetimibe, if they are statin intolerant, if we use the bempedoic acid with the ezetimibe, there is additional 6 to 7% decrease of LDL cholesterol. So bempedoic acid has been studied in a large randomized trial, a CLEAR trial that was published this year. And this study showed that there is significant reduction of composite of cardiovascular death, non-fatal MI, non-fatal stroke, and coronary vascularization. So statin intolerant patient, bempedoic acid is a reasonable option. There are some common side effects associated with bempedoic acid, such as hyperuricemia, gout, cholelithiasis, and tendon rupture. Next. PCSK9 inhibitor. There are two currently injectable forms of PCSK9 inhibitors. One is small interfering RNA that Dr. Mukherjee will discuss, but there are monoclonal antibodies. So evolocumab and alirocumab, those are monoclonal antibodies, and PCSK9 inhibitors has been studied in randomized clinical trials with statin and or ezetimibe therapy. Next. These are the two landmark trials. So if 4-year trial, more than 27,000 patients tested evolocumab, including patients whose LDL was more than 70 or non-HDL cholesterol more than 100. Those patients who are already on statin with or without ezetimibe, mean follow for 2.2 years. And it showed there is a significant reduction in composite of cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary vascularization. On the other hand, alirocumab has been tested in Odyssey trial, almost 19,000 patients. They included patients with acute coronary syndrome within 4 weeks. And they are also on maximally tolerated statin with or without ezetimibe. And they followed as a mean almost 3 years. And it showed exactly similar reduction of composite cardiovascular events and MACE. And you can see both the trials, the absolute risk reduction is approximately 1.5%. Next. So the addition of PCSK9 inhibitor to a statin therapy further reduced the LDL cholesterol anywhere between 43% to 64%. The 4-year trial showed that the additional reduction of LDL was 59%, and Odyssey trial showed that additional LDL reduction was 61%. So basically, mean reduction of extra LDL is around 60% if you use the PCSK9 inhibitor. So it's a very strong very strong LDL reductor. And PCSK9 inhibitors, as I mentioned, is associated with significant reduction of cardiovascular events, especially in very high-risk patients. Next. Patients with PAD, we know, as Dr. Latif mentioned, is a very high-risk patients and are associated with very high cardiovascular events. More reduction of LDL get at the benefit we get even in PAD patients. Unfortunately, in PAD patients, 3/4 of the patients fail to achieve their guideline-directed LDL goal below 70, not even 55, below 70. And half of them had LDL goal more than 100. And the pre-specified subgroup analysis in Odyssey trial and 4-year trial had showed significant reduction of MACE events. Next. So the 4-year trial in a pre-specified analysis showed that evolocumab reduced composite of cardiovascular death, MI, stroke, and other outcomes by 21% in PAD patients, even they don't have PAD symptoms. And they also reduced major adverse limb effect by 42% in all patients and 37% in PAD patients. So basically, PCSK9 inhibitors is very useful in high-risk patients, including the PAD patients. Next. And the Odyssey outcome trial also showed that alirocumab reduced the risk of both PAD events and PAD plus venous thromboembolic events by 31%. And they also reduced the baseline lipoprotein cholesterol. And lipoprotein cholesterol was the indicator, not the LDL reduction in some of these PAD patients with alirocumab. Now, Dr. Mukherjee will carry on, and he will discuss some of the other aspects of our cholesterol management.
Thank you, Dr. Paul. And Dr. Latif and Dr. Paul have set the stage nicely for me to talk about some of the other agents that were already mentioned, but I'll provide a little bit more granular detail. So inclisiran is essentially a PCSK9 inhibitor. It's not an antibody. It's a small interfering RNA which reduces the hepatic synthesis of PCSK9. Again, like PCSK9 inhibitor antibodies, it's add-on therapy typically for patients on maximally tolerated doses of statin and typically with or without ezetimibe. Very robust reduction in LDL levels, similar to PCSK9 antibodies, and really no significant side effects except for injection site adverse events. Was approved about 2 years ago And the dose is 284 milligrams sub-Q injection day 1, day 90, and then every 6 months. So that's an advantage to the antibodies because the injections are less frequent. Next slide, please. I think the key message from this webinar is how do we work together with our patients, our referring physicians, to optimize secondary prevention and reduce cardiovascular events. And our panelists will discuss it in more detail. But I think a key way to do this is to empower our patient and having a checklist for your patients, giving it to them. As your healthcare provider, talk to you about lifestyle changes, which are key. Exercise, cardiac rehab in appropriate patients after an MI or after revascularization, diet. Are they treating your risk factors? Hypertension, diabetes, obesity, other conditions. Has somebody mentioned to the patient their personalized risk using a risk calculator, a CVD risk calculator, reducing risk through diet, exercise, if they're smoking, quitting smoking, whether cholesterol levels are adequately controlled. And Dr. Latif mentioned the optimal LDL level today is 55, not necessarily 70 for high risk, very high risk patients. The need for medications, and if applicable, how therapy is given in addition to statin, how much they cost, their potential drug interaction, need for lipid panel, and only about a third of our patients get repeat lipid panel. Do they have a hereditary risk of hypercholesterolemia, either homozygous or heterozygous? Certainly homozygous statins are not going to work, and you need PCSK9 inhibitors. And for that very difficult patient where you have tried everything, including statin, ezetimibe, PCSK9 inhibitor, their lipids are still suboptimal, maybe referral to a lipid specialist. On the right side of this slide, we have the agents that have been mentioned, and I'm not going to go in detail over everything. So basically, we have 5 agents right now: statins, ezetimibe, the PCSK9 inhibitor antibodies, inclisiran, which is a PCSK9 inhibitor, but a small interfering RNA, and bempedoic acid. Statins are very effective. Dr. Latif showed certainly high-intensity statin, 40–50% reduction in LDL. They're not very expensive today, particularly the generic forms. They can cause some side effects, muscle pains, liver problems rarely, difficulty speaking, sleeping, increased blood sugar. And as I said, they are less expensive than the other agents. Ezetimibe, relatively more expensive. It's oral. It reduces cholesterol absorption, and it is once a day. It's not as effective as statins or some of the other agents, 10–15% reduction, mostly GI side effects, diarrhea and GI or dyspepsia, abdominal pain, sometimes muscle pains. PCSK9 inhibitors, Dr. Paul went over some of the data, very effective, 50–60% reduction. They're actually fairly effective in reducing lipoprotein A also. And in some of the PAD studies, lipoprotein A lowering was a more important predictor. Injections are every 2 to 4 weeks and can be done by the patient. They are expensive, and we'll go over, they do need pre-authorization to be paid by the insurance companies. Inclisiran is a PCSK9 inhibitor, also expensive. The injections are less frequent. The side effects are more local, muscular, at the pain at the site of injection, sometimes trouble breathing. Bempedoic acid is the newest kid on the block. Dr. Paul did go over it. It's, again, for statin intolerant patients, and also for individuals whose LDL is still suboptimal despite being on statin, ezetimibe. It's also an expensive agent, and side effects are muscle spasms, diarrhea. Next slide, please. So in the patient journey, secondary prevention, patients come to us as an interventional cardiologist with a coronary event, typically a heart attack or chest pain or chronic coronary artery disease. And their initial treatment could be, most of the time it's PCI today, stenting with a drug-eluting stent, or sometimes bypass surgery. But very importantly, we need to work with our patients, our referring physicians, and we'll hopefully discuss this in a little more detail. How do we work with a referral cardiologist if we are not prescribing ourselves this medication, how to involve the patient, but making sure the cardiologist discusses the risk with the patient, comprehensive risk factor modification, medications to reduce LDL-C, and potential use of ezetimibe, PCSK9 inhibitors, or bempedoic acid. It is key, as Dr. Latif said, to monitor LDL to make sure for two things, that we are controlling LDL appropriately in the 50s. Also, there is compliance. Discuss any side effects, adjustment of medications to get to the target LDL, and monitor risk factor modification. Next slide, please. PCSK9 inhibitors are expensive. They do need prior authorization and denial appeal. Prior authorization required that healthcare practitioners provide and document the following data for medication approval. Insurance companies will ask for their most recent lipid panel. You have to document that they are not at goal LDL despite maximally tolerated statin with plus minus ezetimibe. And I want to clarify, maximally tolerated statin therapy sometimes can be zero statin. Some patients, we all have patients that do not tolerate any statin, even in the lowest dose. But I want to emphasize, if they're not tolerating high intensity statin, even low dosage of moderate intensity statin is better than no statin. But there are occasional patients who don't tolerate anything, and certainly very reasonable to go to PCSK9 inhibitors in those patients. And history of statin intolerance, if they are not on maximally tolerated statin therapy. I'll share with you a template form that was published in Clinical Cardiology on how to get pre-authorization. If authorization is denied, the appeals process enables clinicians to petition change in insurance provider's decision. And I'll share with you also an appeals letter template. Next slide, please. So this is a typical prior authorization template from Clinical Cardiology. You have to document that the patient is taking maximally tolerated statin, or if they are not on any statin, then you document that they're intolerant. You document their diagnosis of ASCVD and either heterozygous or homozygous familial hypercholesterolemia, and that the patient does have clinical ASCVD. Not going to go over the entire template, but you document what kind of ASCVD they have to justify the insurance company paying for PCSK9 for secondary prevention. Next slide, please. In case your petition gets denied, you appeal that denial. You again document that they have homozygous, heterozygous familial hypercholesterolemia. They are on maximally tolerated statin. They have clinical ASCVD. They require additional LDL lowering based on the guidelines that we need to get them to 55 or lower, and you send it back to the insurance company. Next slide, please. So we have to satisfy the indications for use, and we have to document all clinically relevant information for payer requirements. Use of PCSK9 inhibitor prior auth form in your practice. You can use the template, modify it. If you have samples in your practice, start the patient. If denied, appeal. Act on the decision of the peer-to-peer. If you're denied, ask for a peer-to-peer so that you can talk to a physician to convince them. Engage the patient. They can call their insurance company. And if you have samples, keep the patient on samples. The patient is the most important individual here. If appeal is denied, request a peer-to-peer. Keep fighting for your patient. Deploy social media. Ask the patient to post comments on Twitter, Facebook, pushing the insurance company about the denial. And don't give up. Encourage the patient. Continue to work with the insurance company. These agents not only robustly lower LDL, but they reduce cardiovascular events significantly. Next slide, please. There are some patient resources program work with your clinic manager or your allied health practitioners, is a Repatha Ready, MyPraluent, LegVio Care program to see if your patient qualifies and may get the medication either free or subsidized so that we take care of the patient. Next slide, please. And finally, I do want to mention fenofibrate. It is a triglyceride-lowering agent and added for the treatment of hypertriglyceridemia if other measures fail, including lifestyle modification, management of secondary factors like diabetes, chronic liver disease, if they have failed omega-3 fatty acids. And between the two agents available for lowering triglycerides, fenofibrate is preferred over gemfibrozil when combined with a statin, given the lower risk of severe myopathy. And the clinical trials have not shown that fenofibrate reduces cardiovascular mortality, but they have a modest effect on cardiovascular events reduction in patients receiving statin. I think I'll stop there. Let me turn this over to Dr. Hogan and ask her for insight as a practicing interventional cardiologist and cardiologist. How does she optimize secondary prevention in her patients and some tips and tricks to get them the medications they need? Dr. Hogan?
Oh, well, thank you for having me. That was a fantastic presentation. And
Please unmute Dr. Hogan.
Oh, can you hear me now?
Yes.
Yes.
Great. Okay, sorry about that. Well, thank you for having me. That was a fantastic presentation, and I really appreciate this presentation and the toolkit, which I think really will be helpful to clinicians and patients as well, given kind of the complexity of life and medical care these days. So I can just speak. So I'm an interventional cardiologist at Denver Health Hospital, which is in Denver, and we are the safety net hospital for the area. So we actually serve a large minority population and historically underserved population. I would say that one of the advantages of working at an institution like Denver Health is that the institution really does advocate for its patients. So we are able to ensure that most patients who come in either uninsured or underinsured, we try to supplement their insurance the best we can. And so surprisingly, we are very aggressive with our lipid therapy. Most patients are on high intensity statins and Zetia by the time they reach us. And we do have a large proportion on PCSK9 inhibitors. Because our Denver Health, even Medicaid, will reimburse. Now we do have to get prior auth for that, but surprisingly, we are able to get a lot of patients onto that therapy and achieve aggressive LDL goals. So that's great. And most patients actually do really want to engage. Now, a lot of times you do have to engage the patient, take time with them. We take care of a very large Hispanic population, and we find that family discussions are very important because family members tend to be very close. They live together. Oftentimes, children are helping care for their older parents. And so making sure that they're engaged and in the process is really important because they will ultimately be the ones kind of helping to ensure that the patient receives the care they need. In terms of PCSK9 inhibitors, again, we were able to successfully get people who need them, the medication. The major kind of pushback to the therapy are the site injections, which doesn't happen very often, but occasionally. And then, even more commonly really is just kind of the polypharmacy issue. Because these patients are on so many medications already, just trying to navigate that and try to minimize, take away things that maybe are less effective. So Zetia statins are very common. We do try to go through three statins before declaring somebody as statin intolerant. And in terms of the newer agents, inclisiran and bempedoic acid, we actually have less familiarity with these agents. They're more expensive. And because our pathway with the PCSK9 inhibitors is very successful, we haven't had really as many situations where we need to explore those therapies. But I'm sure with time, that will change. And as our reimbursement changes, we expect that those medications will be available as well. So.
Thank you so much, Dr. Hogan, for that insight. It's very valuable practical insight for a practicing clinician. Dr. Paul?
Yeah, Thank you, Dr. Hogan. This is really good. I want to ask a few questions to you before I start with Dr. Dahl. So in your practice, I know that you describe, but what if I ask you one particular barrier that you face, what would be the number one barriers to start the statin or start the any non-statin therapy to get our goal?
So the number one barrier in our patient population, you know, with the statins, it's not cost, but with everything else in our population, cost really has to be the number one factor. And I would also say, you know, we do have a large population that is unhoused as well. And so consideration for patients that, you know, may have transient housing or how you're going to kind of deal with that and be practical about it. But, you know, when the medications are covered, our participants, our patients are very actually most of the time happy to comply.
Thank you. And Dr. Dahl, if you give your perspective from your practice, how do you deal with statin intolerant patients, how to get our guideline goals?
So my primary practice location is at a VA, and we have an integrated pharmacy group, and there's huge pros and some cons to having that kind of support. I think the pros are if I have a statin intolerant patient, I can send them to pharmacy clinic, and they will do the testing and up titration of various statins for me, and honestly do a much faster and better job at doing that than I would have as a clinician who's unable to see patients every week in some cases, as they do in pharmacy clinic. The potential downside is they follow and they force us to follow a very strict protocol with regard to attempting at least 3 statins. And for some patients who have an LDL of 180 and they have severe myalgias with rosuvastatin, I can tell them that they're not going to get to goal on 2.5 milligrams of rosuvastatin every other day and some ezetimibe, but yet we do go through that exercise. I can't complain because they will go through that exercise with me or for me with my patient, and that's great. I would say a larger problem I'm seeing more recently is people who are refusing to attempt statin therapy because of concern about side effects, and those can be real side effects, and those can be side effects that I think are coming from misinformation that they may be seeing online or on social media. And I have not figured out a good strategy for that. Gentle pressure, showing them their angiograms, giving them my professional expertise. I do think this is a role that interventional cardiologists can step into in a way, because a patient is never more teachable, unfortunately more vulnerable, but also more able to change is that first time you show them their coronary arteries, or when they come in with a myocardial infarction, and that is the time they may be most willing to accept your expertise and try a new medication that they otherwise their uncle or their second cousin told them is going to kill them. So it's, I don't know the answer there, but I actually am having more problems with people who refuse statins than I am with people who try them and then have intolerances at the present moment.
Excellent. So you think that, or in our panel, everybody thinks that I was thinking that adding a pharmacist in a team or extra pharmacist, like a, or maybe like, you know, we have the diabetic educator. So we might need a statin educator, cholesterol educator in the, or like the people who does the lifestyle modification education, all of this. If they are involved, I think it will be more compliant, you know, or they can spend more time basically. I think that we tell what is the indication, we tell that we should be on, but I think that if someone else also tell beyond the physician, I think that might be helpful. Dr. Latif, you there are 2 recent studies came out, very big studies. Also, you also mentioned that in your first gap that half of the patients does not even have after PCI or even within 6 months, they don't have any LDL level, and that's from the study. So how do you approach that? What strategy you would do to decrease that scenario?
So I'll start with my own example. I'm as guilty of that as anybody else. I think I have missed out on checking LDLs on a regular basis. I think the purpose of this webinar first and foremost is to educate myself. that, like what the recent consensus from ACC says, that we should be checking cholesterol every 4 to 12 weeks until we get to target. So I think I do check it frequently, but I was not checking as frequently as 6 weeks. And many times, the patients are also a little bit hesitant to get their blood draws. But, I think the focus of our webinar was on secondary prevention. So most of the patients have had an event. So when patients have had an event, they tend to be a little bit more pliable to taking these medicines, which are life-saving. So I think I have personally changed my practice for the better. I check lipid profiles much more frequently, and try to use all the options that are available. Although I must admit that my office has to go through hurdles trying to achieve that.
Thank you. What we are doing in our practice, anybody come to the cath lab, everybody gets by default the lipid panel with the BMP and CBC when they do the cath. So we make that strategy, and it's really improved our utilization of statin and getting the LDL goal. We have some data for last 2-3 years, so we've been doing this. So that might be strategies as they are coming to the lab for even the diagnostic, if you think, or any kind of procedures they come. That's the one time they're already fasting. You are getting the other labs, one draw. At least you get the baseline and you can act on it. I think that's a good strategy. Dr. Mukherjee, I face some questions to the patients all the time, and I'm struggling with that they are statin intolerant. They have a lot of side effects, and they are concerned about their memory issues. Even today, I saw a patient in the clinic, and he said, "Oh, I had a history of Alzheimer's in my family." You are telling that he had a stent, and he's saying, "Oh, I don't want to statin because I think that I will get Alzheimer's." And he and his wife read about it. Dementia, Alzheimer's, memory issues, diabetes is one of the things they read about it. And how do you convince the patients that, oh, these are not the issues? Because they have preoccupied their head that those are the other side effects behind the muscle pain.
Fair question. And I think Dr. Dahl touched on this a little bit. There is perception. And, if you Google, which most of our patients do, I think you read more about side effects. There is robust data that the mild elevation in glucose or some of the side effects, the benefits significantly outweigh the risk. There's mortality benefit, there's reduction in heart point. That doesn't mean you're going to convince a patient. One of the strategies we do a lot of cardiac rehab, post-MI, post-heart failure, post-CCU admission, and we incorporate that teaching with a pharmacist during their cardiac rehab. We have had some success, but some individual patients are completely convinced that the risks outweigh the benefits, and you're not going to convince them one way, but it works on most of the patients. I think given, you show them slides, you show them figures that the magnitude of benefit, including making them live longer, I think we can convince appropriately based on evidence that these are life-saving medications. There are good things for that patient who is completely against having read about all the side effects about memory reduction. They're going to get diabetes and all these bad things are going to happen. We do have agents. Unfortunately, they're very expensive still. Bempedoic acid is an oral agent for somebody who doesn't want to take injectables. It's not as effective, still 10 to 15% reduction. PCSK9 inhibitors, inclisiran, are extremely effective. There is less, I would say, outcome data still with inclisiran, more robust data. And Dr. Hogan mentioned it's been around longer. What I'm seeing in my own practice, it's getting a little easier to get pre-authorization. I think insurance companies are figuring out that preventing an event eventually will save them more money if they pay for that medication upfront. I think it's a real problem. But I think we're working with their cardiac rehab, patient educator, and particularly a pharmacist talking to them about the risk and benefits and showing the data. Having said that, one of the things, let me ask you and the rest of the panelists, we're all interventional cardiologists. How do you deal with prescribing this medication if the patient is referred by a PCP or a cardiologist? Are you prescribing them yourself? Are you calling the referring physician? Are you telling the patient, giving them a note? How do you avoid stepping on the toes of your referring physician, but at the same time, optimize secondary prevention because they're as much your patient as the referring physicians?
I'm personally managing those lipids, even the PCP referred to us for other reason, or I just check the lipid panel if available. If not available, I just try to get the last lipid panel. If it's not successful, sometimes I'm not successful after multiple communications. So I just check in our lab and I just go from there because with the robust data and definitely decrease all this cardiovascular events. So I'm managing, and then I just call them, say, I started this medication and I'm increasing the dose or adjusting based on this lipid panel. But I'm also at the same time, I do go some outreach clinic, and it's a real challenge to get the baseline lipid panel or follow-up lipid. It's really, really challenge for me. Even if I want to be aggressive, that's why I start with the highest dose, and then we go from there. If they don't tolerate, then decrease. But honestly, multiple attempts I was failed to get the lipid panel because they don't want to come always in the bigger center and the labs. Anybody else have any follow-up?
So a follow-up question to that is, basically, I know we have always talked about a fasting lipid profile, and I know there is some data that maybe fasting is not as important, particularly when you're looking at LDL and stuff. So many times if the patients come to my clinic, and even if I'm seeing them in the afternoon, and I have concerns that this patient is not going to show up for their lab later, I have told them, just go and get your lab done today, and so that you don't have to make an extra trip. And that way, I think I have been successful to some extent.
That is correct. So I also there is no need for fasting anymore. So as soon as I see the patient, my lab is right there. So I get the lipid panel. I have one more experience. I think it's a major one that I felt, and I've been seeing that everybody I talked about want to start the cholesterol. First thing, patient told me that, my PCP told me that my cholesterol is fine. So then it's very hard, and I have many patients because they are so close to the PCP. And you want to change the doses or anything you want to do, they say, I want to talk to my PCP. And PCP said, I just checked the lipid a couple of months ago, very recently, and they said my lipid is fine. So what is happening that if his LDL is 130, is whatever the normal value in the parentheses, they said, oh, your cholesterol is good. They don't think about other ASCVD risk scores or others. So I think there is still room for education to the primary care community or primary care area. What do you think in that? I think there is still lack of education and guidelines.
Yeah, I think one of the slides I showed is empowering the patient, showing them the data, asking them or showing them their ASCVD risk and what the target LDL. You're absolutely right. Depending on the PCP, sometimes, they're looking at what the lab says is normal, and they come back to you saying, why do you want to put me on this? If it's a challenge, and, involving pharmacists, involving other ancillary individuals, and, showing them the data is probably the best way, but still can be challenging if they, most patients trust their physicians, they trust their PCP, they may think that is not necessary.
Thank you. Dr. Dahl, there is a recent study just published last year, and it's a big study, 14 countries, European countries, 9,000 patients, and the name of the study is Santorini study, done by Dr. Kaushik Ray, published in Lancet. And it shows that there is a significant lack of utilization of the statin, like more than 50%. And do you think that it is underestimation of the risk or underutilization of the combination therapy like this? Everybody probably starting some doses of statin to just get the checkbox, like, the metrics, hospital metrics and everything. As long as your statin is 5-10 milligram, it doesn't matter. Your box is checked. But are we not using the combination therapy, either statin plus ezetimibe or statin plus PCSK9 inhibitor upfront? What do you think, then what we should do?
I think it's we see kind of slow uptake of utilization of every drug once it hits the market, obviously. And I think it's a little bit interesting to watch statins that had that same curve and now have plateaued. And I would argue, although I don't know the data perfectly, that we've now started to have more challenges getting patients started on statins. I also think some of these other medications get tarred by the same brush as the statins. In patients' minds, they've heard these things about statins, and then you start talking about other cholesterol medications, and they also have concerns about that. So I do think there's patient-level barriers to get people not only on a statin, but getting them on combination therapy where you can actually get them to a goal of less than 70 or less than 55. All that being said, I think there's a responsibility for us as well as physicians. And I think a lot of us, and I'll talk about myself here. I think when I started in independent practice, if you looked at my procedure notes, I would write aggressive secondary prevention. And that was the extent of what I was doing in this area. And it turns out that people are actually reading those notes. And when I started writing high intensity statin with goal of less than 70, and then better when I started actually ordering the statin, the atorvastatin of 80 milligrams for the patient, and then sending them back to my partner, those patients got put on more medications. Can't cure the whole world, but the people who come through my lab at this point are getting put on the right medications. And I'm adding ezetimibe. And now I'm adding a lot of PCSK9 inhibitors, although as I mentioned before, that's within the context of an algorithm that I don't have full control over. I think in order to get this more broadly used, you got to get to primary care physicians because we still see a relatively small slice of the at-risk population. And your guess is good in mind what the best interventions are. But I do think thinking of all of us as a community and as a group, and again, in the VA, that's really easy. Like I see these people every day, or we have all the same electronic medical record, just knowing that we collectively take care of these patients. It's not your problem. It's not my problem. Like we all need to get them on the right therapy.
Dr. Hogan, so when you order the PCSK9 inhibitors, like how do you in the clinic first time? Because in my experience, I'm trying to enroll some patients for one of the trial. We need 5,000 patients for PCSK9 inhibitor in ACS patients. And every time I talk to the patient, they're a little afraid of the needle. And they said, no, I don't want to take any injection. And then, you know, of course, this is a trial. But in the real situation, do you show them actual, like as Dr. Mukherjee showed in a slide? I think that slide is very important, the patient education with the needle, with the cost. I think that's the money slide. And it tells everything about all the statin, all the non-statin therapy. So I think that should be handy to all cath lab or all in our practice from our SCAI toolkit. But my question to you, that have you ever faced this fear of needle, and they don't want to, or?
Yeah, absolutely. I think it's being patient and sometimes, you know, kind of anticipating that a patient may need to be on a PCSK9. And so kind of preparing them for that and saying, okay, let's, you know, talk about anything else we can do in terms of diet, you know, whatever else we can do to try to get the deal down. But if you're still not reaching goal, like really, you know, to decrease time in the hospital and events and improve your life, this is really the next recommendation. And yes, we do have, you know, we show the patients the first time, and you know that can be a barrier for some patients for sure, but most of our patients are willing to go down that route if we recommend it. So, and I think, you know, the fact that the dosing is less frequent also, that can also be seen as an advantage.
I think we have 2 minutes left. Maybe we can wrap up with a very specific summary. So with this today's webinar, I think the most important part that we all know as a cardiologist that statin is important. On top of the statin, we should use the PCSK9 inhibitor or any kind of non-statin therapy to reduce further LDL to reach our goal. But there is no brainer because we know all the guidelines, but issue are how to convince patients, how to tell the patients to, hey, we have some randomized trial that showed that that even the muscle pain, the placebo patient does not have any, they have more muscle pain than the patient actually taking statins. So we should convince any way that we can. We should involve the pharmacy as Dr. Dahl mentioned, that I think that will increase the more compliance and more patients will be convinced. Those things, and of course, the appeal form is, I think, is very important that everybody should use that appeal form. There's 3 important points: that statin intolerant or tried maximally tolerated doses. Patients have established as CVD or coronary artery disease, and then if still they refuse, then we just do peer-to-peer. And I think from our community, as an interventional cardiologist or a cardiologist, we should be very aggressive to lower our LDL goal, and upfront combination therapy is very important. I think it's 6 o'clock, just right on time. So thank you for attending today. I think everybody will get some good output from this webinar.
And thank you, everyone. Thank you, Dr. Paul and Dr. Latif, Dr. Hogan, Dr. Dahl, for a very enlightening discussion as well as presentation.
Thank you, everyone. Have a good night.
Good night. Bye.
Thank you.
Bye.